Go right into it. Okay, so when we stopped last time, we were talking about this inspiratory flow limitation, where you have your nasal pressure signal, and the more you try to inspire, so here's glottic pressure. So where they're measuring the pressure with an esophageal manometer, and the more you try to breathe, the less air you get. So you have this flattened contour. So we have this, and you see it in here. So no flow limitation. The flow goes up with increasing pressure, but with inspiratory flow limitation, the flow will stop going up even if you're increasing your pressure. Okay, do y'all get that?
Yeah.
Okay. All right. And then maybe we can we change the camera in the
In the sleep lab?
in the conference room, so I can see the fellows who are there.
Just Kate today, I think.
Oh, it's just Kate, and then everyone else is on.
We're all at home.
Okay.
On video.
All right, well, you can turn your cameras on. I'm gonna make you turn your cameras on.
That's right. That's right. Don't be afraid to show your faces.
That's right. Okay. And so, like I said this last time, inspiratory flow limitation, it's a small amount of it is normal, but not much. So in a study that did PSGs on people who were asymptomatic, so no sleep complaints, this was done in Brazil, and they found that asymptomatic people had, about 9% of breaths showed inspiratory flow limitation, and the upper limit of normal was about 31%, and like above that we should consider it abnormal. So I think of flow limitation as a really important thing to look at when you're looking at a PSG and deciding, is this a normal study or is it not? And like, sort of spoiler alert, just about everyone who's referred for a sleep complaint does not have a normal study. Like, I have yet, after thousands of sleep studies, I have yet to see an actual normal study in someone who was symptomatic. The only normal studies I've seen have been in people who are referred because they needed a sleep study for bariatric surgery or because they work in transportation. Those are the only people I've seen normal studies in. Oh, and there was one guy who was sent by his cardiologist because he developed atrial fibrillation. And so of course he needed a sleep study, but he had rheumatic valvular disease. And I'm like, okay. Anyway, so this flow limitation can have positionality. It tends to be worse supine. So for two reasons. One is there's gravity, your tongue's going to be falling back. And then there's also a loss of tension where your lung volumes are larger when you are non-supine, or when you're on your lateral position compared with when you are on your back. Your lung volumes, I don't know what the lung volumes are prone. Kingman, are you around? all right, whatever. With the prone positioning, I don't know what, I know you need.
Yeah, you do, you push up your diaphragm.
Huh?
Prone, you push up your diaphragm.
So it's a smaller lung volume?
Yeah.
Yeah. And
more, but it's also, and it's a more effective diaphragm because it's longer. So when it given the same amount of activation, if it's longer, it has more tension. I'm sorry I had to walk away for a second, but did everybody understand the flow limitation in terms of the pressure flow? I mean, Suzanne and the guys, because they're remarkably quiet sometimes when we talk about pulmonary stuff. Right? I should swallow a balloon and show you the negative pressure every time you take a breath. Okay.
Yeah. And so that negative pressure that people are fighting against, that negative pressure can cause arousals. And it's been shown, like, that's part of your arousability threshold. Some people will arouse with like a really small negative pressure, but some people will take them, they have to get to like -30 to wake up, but some people will wake up at -10. And so that's just part of your, the phenotyping of sleep apnea. And so this flow limitation can have a lot of consequences. So even like mild sleep apnea, or even with an AHI less than 5, people can have significant physiologic consequences on this where they disturb their sleep. And this, like I said, this is not included in ASM scoring. I think eventually it should, but there needs to be a lot more research. And then if you can see, like, PLMs are often related to inspiratory or expiratory flow limitation, and you can see that like on an everyday basis. And like when I do a sleep report, I'll make a comment on whether the PLMs are like maybe respiratory related, even in the absence of actual events. And so you guys said you didn't hear about Starling resistors, so I will make a little teach you a little bit about Starling resistors, which is a concept for understanding how pressure affects the airway, in this thing called P-crit. Have you guys heard about P-crit?
Yeah.
Yes. Okay. So P-crit is part of this concept of the Starling resistor. So you consider it as a collapsible tube in the sealed box. And so there's pressure in the sealed box, but then there's like this area, which is collapsible. And whether it collapses or not is going to be dependent on the pressure in the box, which is like pre-out or P-crit, versus the pressure on either side of the tube. And so let me quickly mute everything here. A second. All right, sorry about that. So, and this is from that Berry book, Fundamentals of or Essentials of Sleep Medicine, in chapter 16. And so flow will only occur when the pressure in this collapsible segment is greater than P out. Do you guys see that? Otherwise, it's going to collapse. Yes? All right.
Yes.
And so, you know, there's a couple different situations. So if you look at a situation where, see, this is the upstream here and the downstream here. If the upstream pressure is less than the pressure in the box, obviously nothing's going to flow into it. So the tube is going to be fully
The
collapsed.
thing about upstream pressure is what's measured in the CPAP mask. Right.
Right.
Okay.
And then a situation where the tube would be fully open would be where both the upstream and the downstream pressures are greater than the flow in the box, than the pressure in the box. So obviously it's going to hold it open the whole time. And then the flow is just going to be proportional to the pressure between upstream and downstream. And so this is the non-flow limited state. Do you guys get that? So the pressure, this pressure in the box, it doesn't factor into the flow that you get with whatever, you know, negative pressure that you're trying to inhale against this. Yes? All right. And so the situation that we're talking about is this flow limited state. And at this point, in this situation, the upstream pressure, so like the pressure in your throat or like up in your nose, is greater than the pressure in the box, but the pressure below this box is less than the pressure. And so you see that it's going to be higher here. It can easily flow in, but once you get to this point, there's going to be collapse to the extent where flow is allowed, that it creates this pressure, like this local pressure where of like this plus 10. And so there you end up with fluttering until you get the stable pressure. Does that make sense to you guys? And so at that point, then the velocity of the amount of flow is going to be determined by the upstream pressure minus P crit, rather than, and then versus the resistance, rather than the pressure between upstream and downstream. And so this is the flow limited state. So the difference in now the flow is going to be dependent on the pressure in the box, or P crit. And so now you're adding CPAP. CPAP is going to be actually adding pressure here to hold this open. So it's actually this downstream pressure that's important for CPAP. So that it can hold. Do you guys understand that concept? Because I think this is actually an important point, that this is where CPAP works. It's not at the upstream pressure, it's at the downstream pressure, and that's to hold that airway open. So we no longer have this problem. So we're adding on to the pressure downstream. And there's actually, I'm going to show you a video which shows this really nicely, that it's actually this expiratory, this end expiratory pressure that opens the airway. So this is a video that was from Isono's group in Japan, where they did this nasendoscopy during during anesthesia. And then they increased the amount of PEEP. And so just to show, so they put the scope is going down the nose, and we're seeing the soft palate is right here. So the inspiratory pressure is 18 and the expiratory pressure is going to be changed. So now we're at a low point. We're seeing the soft palate balloon into the airway. This is the posterior wall of the pharynx. The lateral walls are here, and here's the soft palate. So you can see as the positive expiratory pressure is increasing. Just watch. Inspiratory pressure is the same. It's still 18.
Wouldn't take much.
And now at 8, now that palate is, the soft palate's being held. You see that? So it's the expiratory pressure that's really, really critical for opening the airway. And that's something that we don't do a good job at teaching our sleep techs about. But now you guys know. So like when I write reports, I always say, like, start the titration with an expiratory pressure of this, if you know, have a failed CPAP titration. All right. And so you can measure P-crit in the sleep lab. It's actually very simple. And you do a bunch of pressure drops. And so this is the flow that you would measure just with your CPAP, you know, and we know we can measure the CPAP. CPAP can measure flow really easily because they have their whole little resistance thing, and they can measure the pressure on either side of it. And then here is the pressure that's being applied with the CPAP. And so you just drop it and you see what the flow is at each point. And P-crit is where this where this line intersects the x-axis. So this person is going to collapse their airway at a positive pressure of 1.2, which is, well, above atmospheric pressure. So when they're asleep, boom. Yes?
Boom.
All right. And so P-crit, this is one of Kingman's slides. So P-crit is important for everyone. And so if you have a P-crit that's positive, you're always going to have OSA. Like you just saw, it's a physical impossibility for your airway not to collapse if your P-crit is positive. Boom, it's done. And then if your airway is like really, if it takes a lot of negative pressure to collapse your airway, you're probably going to be pretty good. And here we have this vulnerable anatomy where people could go either way. And so these are the airways that are a little bit floppy, but they're not, you know, absolutely going to collapse. And, you know, you need a little bit of, here, you need a little bit of negative pressure to get the air moving. So this is going to be a little bit less than, little bit of in the negative range. And so the Starling resistor, it's an important concept, but it doesn't tell the whole story. So we need to understand what's going on with this vulnerable model or this vulnerable anatomy. And so here we have, this is what the Starling resistor kind of would look like if you simplified it. You have the nose, and this is flipped the other way, but this is upstream, here's downstream, and then here's the pharyngeal wall. And so the collapsible section of the airway being the pharyngeal walls would be, you know, this would be simple. And if it were this simple, CPAP would be a piece of cake. But anatomy is a lot more complicated than just the lateral walls. because there's all sorts of other bits. And the other thing is a Starling resistor doesn't explain expiratory flow limitation, which also occurs. So here is the anatomy. So you can have these floppy bits in the airway, which are like high compliance, which would be the soft palate and the epiglottis. And then you have the low compliance thing, which would be the tongue. And then
Great slide.
You like
never
that.
never seen that. That's good. Good slide.
And then the jaw too. So like the whole thing can fall right in there.
Oh, got everything.
All right. So we'll talk about negative.
Let me just go back to that one slide
Sure.
there without the jaw. Yeah, so the issue becomes that the Starling resistor was the big thing in the 86, and Johns Hopkins, Alan Schwartz, Bert, Saul Permit, and other guys that were there really opened that up. And then the crackback block came when Wellman was looking into the airway and said that the Starling resistor doesn't do everything. And Remmers came up with this idea that the tongue is like a chock-a-block. It's like a pump that is much more of a open closed sort of thing. And so it really is a combination of both those things. So that's really what you're showing. So the floppy parts can really flop around. And whatever it is there can like the jaw moving backwards or the tongue and the meat kind of going backwards. It's much more of a different kind of valve. It's called it's not a resistor, it's a valve. It's more of a valve thing. So
Right.
and your nasal entry is more of a valve, right? It's a valve rather than, even though it can act as a Starling resistor. Okay.
Right. And you know, just sort of a practical thing is that like this jaw is really heavy and that take a lot of pressure to hold that up. But if you were to give someone who needs that sort of pressure an oral appliance which hold their jaw forward, much less pressure needed then to control the rest of the airway. So, and that's totally underused, like you having dual therapy to control the jaw and the back of the tongue. So anyway, so we'll talk about negative effort dependence. And so this was this study that spawned the talk. And so just looking at here, so here we have the eye leads on at the top, chin, EEG. We have the nasal pressure, oronasal thermistor. We have our effort bands here, pleth, legs. And so this is an N1. And then the next epoch, this patient went into REM. And so same things. And now anyone want to describe what's going on with this nasal pressure signal?
Hey, you may have to get up and get really close to the screen. That's why it's nice to have a big screen. So the other thing is negative effort dependence is a term. And so when they say effort belts, that's not the same. So it's negative effort dependence. So the definition is
Of negative effort dependence? It's when you're
well, you'll define it. But what's happening there?
Huh?
What's happening in that inspiratory flow?
Someone other than
you see that? Kate, you see that?
I think.
Sydney, you see that? We were looking at that the other day.
Yeah. Yes, I can try to interpret it. So
What
we
is
have,
it? What is it? What is it?
so we got two epochs here. One is N1, one is REM, and just going down from left and across the various flow signals. It seems like in REM sleep, there's more of a biphasic component to the nasal pressure and some paradoxical breathing and some flow limitation, more in REM sleep associated with more desaturation, so more like not classic obstructions, but maybe some hypopneas or that close.
So what's happening right here where I have, do you see my cursor?
Yeah.
So what's happening right here?
Yeah, that could be that that negative end expiratory pressure kind of opening up that
Yeah, so
bottle space
the
again.
airway's closed right here, briefly. But so here we see there's airflow, close, and then there's a little bit of more inhalation, and then there's an exhalation. And now the next breath, it starts to inhale, the airway's shutting, then it's opening back up, and then we have an exhalation. And at the same time that this is happening, we have paradoxical movement of the chest and the abdomen. So this is this airway is actually collapsing suddenly during in the middle of inhalation and then opening back up. So this is negative effort dependence. And then as the person is starting to relax, it opens back up. You see that? So this closure is happening towards the peak of inhalation. You guys see that? And so this is negative effort dependence. And this is not something that you would expect from that Starling resistor. This is what's going on with those floppy bits in the airway. Okay, does anyone have questions about this?
Well, you can see it in a Starling resistor, but what it means is it moves. It moves, because this actually comes from the concept of flow limitation in the lungs, except it's flipped on during expiration in the lungs. This is flipped on inspiration in the upper airway. So that's how the concept came.
All right.
But there are instances as you blow out during an expiratory flow volume loop, in which you can see that there is effort dependence. That is, if you do it very gently, you'll have a higher flow than if you really push it. And that just means there are parts of your tracheobronchial tree that are flow limited at certain lung volumes. And here, it's the same thing. It's just that your inspiratory flow at certain parts of your inspiratory effort show the harder you're pulling, the less flow you're getting. That's the background. I didn't mean to step on your lines.
That's fine. And so this is someone who, this patient was a 36-year-old man at the VA who had really severe psychiatric comorbidities. His home sleep test had it was just like 0.9 was the REI, but he had oral stigmata of OSA, and that this is like mild sleep apnea, but it was really severe in REM, and you can see this. And he had this high frequency intrusion throughout his EEG. So he's not sleeping well. And when I see this, I'm like, I think that this has a big impact on his brain health if he's not able to breathe during REM sleep like that. So negative effort dependence, this is this reduction in inspiratory flow with increasing effort. It's common in OSA, but there's a lot of variability between subjects. So it can range from like 0% to 89%. And it tends to be fairly consistent. So if you have someone who has negative effort dependence, they usually have it like throughout the night, and it may be dependent on position and sleep phase. So it's usually worse during REM and it's worse supine, but I'll often see like hints of it throughout, like even little bits in non-supine and REM. But if you see supine REM, it's usually like much worse. And then there's
Put the left-hand side,
huh?
Describe the figure.
Oh, describe that. Okay. This was a repeat from last time. But so here, this is minimal negative effort dependence. So there's really not, it's like less than 25%. Here we're looking at flow on the y-axis and then time here during the breath. And so these breaths have minimal negative effort dependence. This one has mild So it's between 25 and 50% negative effort dependence. And then this is severe, where your airway is actually like closing or coming close to closing. And I usually will grade, I'll be like, you know, mild to moderate negative effort dependence or severe. That's basically how I note these when I'm reading sleep studies. And so sometimes the negative effort dependence, the airway will relax open and return to baseline. And so you'll get this little terminal peak as it's coming, it's like popping back up to baseline. So here is this esophageal pressure on the top and the flow here on the bottom. And this is just time, different breaths. And then you can have an airway which is like closes during mid-inspiration and doesn't relax open sufficiently. And so there's going to have a progressive increase of effort until you end up with a full collapse. So here we have partial collapse. Here we end up with full collapse. But so these pressure shapes can actually help us understand what's going on in the airway. Let me just, oops, I just messed something up. All right, I managed to get, oh, there you guys are. All right, I changed something on my screen. All right, so here is this terminal peak. And how this looks can help us understand stuff. So we're relaxing open. So now we're going to go to our anatomy review. So here is a cross section of the head. We have the hard palate, the soft palate, the tongue. This is the epiglottis and the hyoid bone. And so these are dynamic structures. So the soft palate, the epiglottis are really dynamic structures, and the lateral walls are dynamic as well. So these are all muscles or controlled by muscles. These aren't skeletal constituents. The tongue is less compliant just because it's so big and it's kind of anchored to your jawbone. But this is just going to be a floppy bit, and the soft palate and the epiglottis are really floppy bits. And you can observe like the changes in the airflow can give us an idea of what's actually collapsing. So this is a cool study by Genta and colleagues. They're over at Harvard. And so they use a nase endoscope and a flow signal and a pressure catheter to figure out how the flow signal changes depending on what is collapsing in the airway. And so here they have the endoscope going through here. They have the pressure catheter. Now you're looking from above. And so you're looking down at the soft palate here. Here's the posterior pharyngeal wall. You can barely see the epiglottis is like this little thing down here. And then if you advance the scope a little bit further so you get past the soft palate, then you'll see the epiglottis better. So then this is the tongue base, and the epiglottis is at the tongue base. So it's this little floppy cartilage like that's attached to the tongue base, and there's a space between the tongue base and the epiglottis. That's the vallecula. So here they call this the obliterated vallecula just because the tongue and the epiglottis are stuck together in this picture. So they used 31 subjects with OSA. They all had severe OSA. This was like a mean AHI of 54. And then they gave a little bit of CPAP to relieve flow limitations so they could get stable sleep. And then they removed it in like 2 to 3 minute intervals so that they could see what was going on, and then added a little bit back so that they got stable flow limitations. So they had to play with this to see this. And what they found is that tongue-based obstruction caused very little negative effort dependence. It just caused flow limitation. So these were tracings from single subjects and multiple tracings. And these were what the pictures look like. So here is the tongue coming backwards into the pharynx. And so here was like a little bit of negative effort dependence, but it's mild. It's all very mild negative effort dependence with the tongue, and it's really just smooth. So this is what tongue-based obstruction will look like in your nasal, or this was a pneumotachometer. So it would be your nasal pressure signal if you had your mouth close to your nasal pressure, if you had your mouth taped shut. So they're capturing everything that's coming out of the airway. And then this is what tongue base obstruction looked like in a video. So I will show, oh, actually, no. So I will, oh, it's the next one. I'm going to show you a video with the next one, but this is what the pictures look like. So this is viewed from above. So you viewed from the velopharynx. So this is going to be the soft palate here. And then viewed from the oropharynx, here is the epiglottis. Do you guys see the epiglottis? And so we have the flow here, inspiratory flow limitation, and then here is the pressure. And so you see there's this increased pressure, flow limitation, increased pressure. And it looks very similar from above. And then here's the video. So you can see what it looks like. And it's actually really boring because it's you don't see much movement in the airway. It's just flow limited. But things get more interesting. Oh, here's the oropharyngeal view. So again, there's a little bit more movement now with the in the oropharyngeal view. But so that's tongue base obstruction.
So I've
Sure.
noticed that on sleep studies before. But when I saw that, there's also significant snoring with it. I thought, oh, maybe, I don't know, snoring is causing that. I didn't really realize that we know what true causes tongue-based obstruction. That's good. Thank you.
Yeah. And you know, when you see this jaggedness on the flow, that's often snoring right there. All right. And so then with the soft palate, things move a little bit better. So now you're going to get some mild to moderate negative effort dependence when the soft palate is collapsing. So these were all different subjects. Their collapse looked a little bit different in each one, but they were all pretty similar. And
So go back to the previous.
okay.
So you see that little gray around the line?
Mm-hmm.
Those gray are all 50 different breaths. So that's the median of 50 different breaths. So that's your standard deviation. So you can look
Exactly.
at, right? I mean, that's,
Yep.
that's nice. Okay.
All right. And so this is what it looked like when they looked at the flow and the pressure gauge. And so here you could actually see much more increase or decrease in the caliber of the airway. So this is so we're looking from above, and this is the soft palate being open at the beginning of inspiration. And then this is where the soft palate's closing during the flow limited section of the inhalation. And this is what it looks like in video. So that is velopharyngeal collapse. And this is actually concentric collapse. If you're interested in so that the lateral walls are closing in at the same time, the soft palate's doing an AP collapse. So that's concentric collapse. I don't have a video of AP collapse for, you know, the whole Inspire thing. And then lateral walls are also pretty compliant. And so they found this moderate negative effort dependence in the lateral walls. And as Kingman said, this is from each patient. These are a bunch of breaths. And then this was like the average. And so now we're looking down. So we're now past the velopharynx, and we're looking, we can see the epiglottis here. And these are the lateral walls on each side. So there's the tongue base, the epiglottis, and lateral walls. And so you can see the lateral walls coming in laterally. And this is what it looks like. I'm going to show you the video after this one. But so you can see at the beginning of inspiration, the lateral walls are kind of collapsing like that. And then in the flow limited, it's, you know, quite tight in there. And so this is what the video looks like, as you see that. So this is lateral wall collapse.
Okay.
And so there's kind of like this like U-shaped where it relaxes open. See that like little U shape? And now epiglottis is where it gets really cool. And epiglottis is the one that you can actually get a fairly good idea of what's going on when you're reading a sleep study. And so this is the epiglottis. And this is a bad picture, but I'm going to show you some more videos. This is really dark, but this is the epiglottis. The tongue base is here and the posterior wall is here. And so this is, the airway is open. And in here, you can see this epiglottis has flipped over towards the posterior wall. And this is what it showed on the flow. So unobstructed breaths. And then there was a middle, in the middle of inhalation, suddenly this epiglottis collapsed shut. And so what does this look like? So let me show you the anatomy here. So here's your epiglottis. So it is this cartilaginous flap. It has ligaments on the base of the tongue. There's actually some muscle from, like, there's a genioglossus tendon into the epiglottis. And it's part of the larynx. Hyoid bone is here. And then your vocal cords are down here.
There's a hyoepiglottic ligament.
Yes. And so there are, so here, if you look down, if you were like looking and doing a laryngoscope, here are the vocal cords. The epiglottis is right above there. And here's the tongue base. And so there's a space, there's a vertical space here. And so this epiglottis, actually, when you swallow, the epiglottis flips over and covers the larynx during normal swallowing. And there's muscles, there aren't muscles that are actually attached to the epiglottis itself, but it's it's like a sort of a soft tissue pouch, and muscles insert into that soft tissue pouch. So the epiglottis is mobile and is controlled by these muscles. And some of them are these swallowing muscles like palatopharyngeus and stylopharyngeus are both involved in controlling the movements of the epiglottis. All right, and so here's the tongue base. And these were just muscle to the soft palate. We have palatoglossus and palatopharyngeus coming down. And so negative pressure, this is a great video. This is from Stephen Park. He had this on his website. He's an ENT doc who's interested in sleep. And so this is negative effort dependence in the epiglottis. And so it's doing this AP collapse. And at the end of the video, they did a jaw thrust, and the jaw thrust of pulling the jaw forward, because the epiglottis is attached to the tongue. If you bring the jaw forward, that brings the tongue base forward, and that brings the epiglottis forward, and that can open the airway. The other way that that this can be opened up, about half of people with the epiglottic collapse will improve with positioning. So you get them on their sides, and that will help. And some people it doesn't help. But so this is something that I will recommend in people who are struggling with CPAP and have epiglottic collapse on there, or signatures epiglottic collapse. It'd be like, yeah, maybe an oral appliance combined with CPAP might work a little bit better. Unfortunately, there haven't been studies specifically into that, but there have been studies that have shown that combined CPAP and oral appliances can improve the success of CPAP considerably in patients who are difficult to treat. So, and you guys want to see that again, or you got it?
See it again.
See it again. All right. And so you can also see when you have, this is like a sail. If you're putting air on there, from like, if you put like 10 centimeters of water air pressure on there, that can, if you have a floppy epiglottis, that can close your airway. It's like a sail. So a lot of people with a floppy epiglottis often have a lot of trouble with CPAP.
Mm.
So when patients say, I can't tolerate CPAP, if this is happening, they really can't. They can't breathe with it. So, all right. And so there's another way. So the epiglottis can collapse in this AP direction. It can also collapse in a lateral direction. And so this patient had more of this sort of lateral collapse. So it doesn't take much. So remember the epiglottic pressure? So first, we're like right down there. So the pressure difference is much less. The pressure gradient where we're measuring, but it really doesn't take much to collapse the epiglottis. And so here we have the flow. And here at the beginning of inspiration, we've got like a little tube to breathe through. And then it closes up in the middle of inspiration. And what you can really see here is that this collapse is sudden. It goes boom. And so you're looking for these abrupt discontinuities in the flow signal. And that's a signature of epiglottic collapse. And it's a severe negative effort dependence. And the next slide here will show.
Go back a second.
Yeah.
So the other is, you notice the epiglottis centimeters of water is 2. And then you have flow there. That means that there's no resistance from the nose all the way down to the epiglottis. There's very little resistance. It's not a high pressure down there. So the obstruction really is at the level of the epiglottis. It's not at the nasopharynx, it's not at the oropharynx, it's the epiglottis. So that's another thing in this particular example.
All right. So here is our video. So showing that. And I'm always amazed, like, how do people even breathe with this? Like, look how little. This is right above their larynx. I mean, that's just shocking. But you see this, so you can pay attention when you're reading sleep studies. When you see this sort of stuff, that's what's going on in the airway. Anyway. So epiglottic collapse, we have the sudden negative effort dependences, abrupt discontinuities. And you can have this negative effort, you can have just this without the discontinuities. That can be epiglottic collapse. But when you're seeing something like this, you absolutely know that the epiglottis is involved. And during unobstructed breath, the epiglottis may not completely open. And so remember with this like this thing is not completely opening between breaths. That's what's going on in the epiglottis. And when it's really narrow like that, it's really vulnerable to sudden obstruction. And you can also imagine, like, this is a really tenuous airway. And so like that patient that I was showing you at the beginning of this section, that VA patient who was like 36 and had an AHI of 6.5, this is probably what was going on with him. And this is hard to breathe. So isolated epiglottic collapse is rare. So only 2 out of 9 patients in this study had isolated epiglottis collapse. The rest were associated with other sites. And that's consistent with like larger studies using drug-induced sleep endoscopy, that usually there's multi-level collapse and is usually not only at the epiglottis. But the epiglottis can be really important in some patients, particularly as it pertains to being able to tolerate CPAP. And so implications of epiglottic collapse, it does occur more frequently than previously thought. It's about 30% of patients. And you can't really tell on an awake exam if someone is going to have epiglottic collapse. And like I said, it can worsen CPAP intolerance. And it also complicate surgical success rates. So, some sleep surgeons, that you can actually go in and take out the epiglottis. This was a big surprise. You actually don't need the epiglottis to swallow properly. So in worst case scenarios, they'll take it out. I'm not a big fan because I actually think we can fix epiglottic collapse with speech, like swallowing exercises. But that's my current research project. But then, like I said, positional therapy may help with epiglottic collapse. So 50% will improve if you just put them on their side, and then the other, you can also consider the oral appliances. And so this is an example of the positional therapy in epiglottic collapse. So this is a patient who had epiglottic collapse. So while supine, and then this is and you put him on the side and he did pretty good. But then here's a patient who had epiglottic collapse supine, but you put him on his side and it still looked pretty bad. So kind of to wrap things up, this is like this study, there's like a little flow chart that they put in here. So a posterior located tongue will cause pretty stable flow limitation. Collapse at the lateral walls will cause sort of this moderate flow limitation or negative effort dependence. Isolated palate, sort of mild to moderate negative effort dependence, and then the epiglottis will cause this sharp discontinuities. And so here their flow chart: minimal, tongue-related, moderate, lateral walls, isolated palate, epiglottis, and then again the sharp discontinuities or large negative effort dependence is, attributable to the epiglottis. So, all right. So we talked about inspiratory flow limitation, but wait, there's more. There's expiratory flow limitation. And so this is another thing that you're going to see. It's common and you're going to be like, oh, I never noticed that. So expiratory flow limitation. So, normal air comes in, but then what can happen when air comes out, if the soft palate balloons up, the air will either get blocked by the tongue, will get shunted into the mouth and can get blocked by the tongue and you get airway stacking, or it just escapes from the mouth and you don't detect it in your nasal pressure. And so this is called palatal prolapse. And this is a great paper. If you're interested in this, this is a really good paper to read. So Azerbaijan. And so this is just ballooning of the soft palate. And here they use a pneumotac to look at nasal flow. And they had some pictures here. So here they measured epiglottic pressure. And so this is inspiration is negative and expiration is a positive pressure. And so looking here, here's a normal breath. Here's a normal breath, but then something funny happens during exhalation. You see, so I want you to focus on the expiratory limb here. You see that? This is a normal relaxing, and then suddenly this is no longer a normal relax. It just closed. And so this is that palatal prolapse again. And notice the positive pressure, the epiglottic pressure became more positive. More positive, more positive. So they're having breath stacking, causing an increased positive expiratory pressure because they're not actually doing full exhalations. And then the airway opens back up. So now there's a normal exhalation again. So here you can see this palate, it was going in, and now this palate's opened up again. You have some relatively normal inspirations, a little bit of flow limitation, and then it does it again. And so this is this palatal prolapse. And here you're going to see a picture of it or video of it. So this is like what I had showed you before. So you're looking down. This is that expiratory palatal prolapse. The air is being kept from exhaling through the nose. And you will see this pretty frequently on sleep studies. And you can see it on CPAP a lot. All right. So significance of palatal prolapse, it predicts isolated inspiratory palatal flow limitation. You'll get this mouth leak with nasal CPAP, which will obviously cause a loss of therapeutic pressure and also causes arousals. And so whenever you have this changing back and forth between an oral and a nasal breathing route, there's actually an arousal. And so we like to go to full face mask when there's a problem with mouth leak, but people do have more arousals with the full face mask. So full face mask may be good if you can stabilize the airway, but if you're still dealing with this, the full face mask may not really help with sleep. And I think this is one of the reasons why there's a lot of problems with, or more problems with long-term compliance with the full face masks. You've got to be a lot more more conscious about your minimum pressure if you're using an auto CPAP when you have the full face mask, because you have to make sure you get remember that slide that the video I showed you with that expiratory pressure, that you had to get to an expiratory pressure of 8 in that subject before you could hold the airway open. If you're starting with an expiratory pressure of 5 and auto PAP, you're going to start having this boom, 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 right? So with a full face mask, you're going to need a higher expiratory pressure to hold that airway open for successful therapy. All right. Anyway, now I'm just going to wrap things up here. So normal studies. And this is like, whenever I see a normal study show up, I'm like, 9 times out of 10, I got to send it back for restoring. Because there are very few normal studies. We get a fair number of studies which have an AHI less than 5, but they're often, most of the time, they're actually not normal. Usually they're underscored. But if you have an AHI less than 5, but there's a ton of flow limitation and arousals, this is not a normal study. And like, please, please, please don't gaslight a patient and say a normal study. Like this is sleep disordered breathing that does not meet scoring criteria, for OSA. And oftentimes it does, and you just need to send it back for rescoring. So I will send stuff back for rescoring unless I look at the study and I'm like, there's nothing I could score here. And then I'll just say it's like sleep disordered breathing. And then especially check for thoraco-abdominal dysynchrony and paradoxing during REM, and especially supine REM. Like, you cannot rule out sleep apnea unless you've got supine REM, because there's a fair number of people who will really only, like with mild OSA, who only really manifest in the supine REM. Like that patient who had the AHI or the REI of 0.9 on their home sleep test. Like, we needed to get him in the sleep lab and make sure he had supine sleep to get him up to a 6.5 on the AHI, but he clearly had bad, sleep disordered breathing. And then the other thing to pay attention to is that this nasal pressure signal, if you can't use the nasal pressure signal, you have reduced sensitivity, because then you're relying on this oronasal thermistor, which we, like from the last time I talked, is like the oronasal thermistor is really poor at showing they're very poor for hypopnea detection. But oftentimes, now on the flip side, a lot of techs will only score off the nasal pressure signal if it's present. But if we're in a situation of this oronasal breathing, like I said, you will sometimes see the events better in the oronasal thermistor signal than you will on the nasal pressure signal, because your nasal pressure signal might just be showing severe flow limitation, nasal flow limitation and exhalation. But the oronasal signal, the thermistor, might actually be showing the hypopnea. So I have a fair number of studies where I sent for rescoring and I said, use the oronasal thermistor, because that was the channel that was showing the hypopneas better than the nasal pressure signal. So you need to really look at both signals whenever you're confronted with the so-called normal study. And remember that normal study, remember that beast? It's like everything was regular. You don't see them very often, but when you see a normal study where everything is regular, that's your normal study. So summary. So you
Usually
need,
prior to an MSLT.
huh?
Usually prior to an MSLT.
Yes. Well, the only time I've seen that, like I said, the normal studies are the bariatric patients or the transportation patients. Yeah. So anyway, so knowing to read the sleep, the flow signals and the respiratory signals well will make you a savvy sleep doc. And it's important to be able to spot significant sleep disordered breathing that's underestimated by the AHI. And then understanding like where and how this collapse occurs could help individualize therapy. Like I like to call out that epiglottis collapse. so that people don't get the CPAP and go like, oh my God, this is horrible. I'm like, for these patients, I usually will say, have the patient do positional therapy, use low pressures. Like, don't give them an AutoPAP 5 to 20. God, that's not going to work in a person with epiglottic collapse. But they may do okay with positional therapy and then a low pressure. I'll say try like 5 to 8. If they don't do that, try just 5. And they may actually do well on that. Or bring them in for a titration. But some of these patients will really struggle with higher pressures, and you got to listen to that. Early CPAP follow-up, and then, like I said, oral appliance therapy. And I really need to do a study like with oral appliance and like combined oral appliance and CPAP, looking at these flow signals, because I think that there's a lot that we can learn from these flow signals to individualize therapy a little bit more. And so here's some selected references. This is a nice paper, this Pamiti. It's an ATS workshop report on inspiratory flow limitation, and this Henta study, and then this Azerbaijan. And I can email those to you if you'd like. Yes?
Yes.
All right.